Sevgili arkadaşlar,
Dear colleagues, dear professors, it is 5:05, so we may start. I would like to briefly inform you about Dr. James. Dr. James is an adolescent and adult psychiatrist in United Kingdom, and he is one of the pioneers. Indeed, we are quite glad to have him here. We thank him for coming here. He is also senior professor in his field in Oxford University. He has a research career in regard to adolescent diseases, and in longitudinal imaging studies he was involved, and he is still part of lots of multinational studies. And he is working on dialectic behavioral therapy for adolescents. And at this point, one of his current interest area is the treatment-resistant depression in adolescents. We once again welcome him, and the floor is yours, sir.
Okay. Well, first of all, I'd like to thank very much the organizers for inviting me here today. And I'm very grateful. I did think that when you reach my age, you'd come and you'd kind of give a talk, and that's the whole point of it, really, to expound your ideas and your knowledge. But actually, that's not the case at all. I'm here today to try to help you guys who are younger, enthusiastic, and have the field in front of you to learn, to ask questions. I may not know the answers to these, but if we can get a few questions to think about how we can research it in the future, then there's something useful to come out of this meeting. But what I can do is give you some information that we have to date. And there are some inconsistencies. You'll see an inconsistency in the talk in terms of definition, which seems to me to be pretty fundamental. I am particularly grateful for those who actually don't speak English. Are you getting the translation okay? You are. If I'm not, put your hands up and then I'll slow down. Okay, I'm very grateful, because that's even more painful. Yeah. So it's an important subject. And first of all, what I'd like to point out is this is not a unidisciplinary effort. This is Rachel Hogan, who is a lead pharmacist, and we work together and have set up a clinic for those with treatment-resistant depression. So what I'm going to do today is talk about the clinic and hopefully inspire you to think about perhaps setting up one of your own, or if you already have one, I'd like to hear your views. But what I'm going to do is take you through some of the background knowledge we have about depression in young people, then go on to think about treatment resistance, and then what we can do about it. Is that okay? If anyone's got any questions, I really like this to be interactive. Just put your hands up and we'll see what we can do. Okay. So, depression. You don't have to go very far in Turkey or in the UK to see pictures like this with depressed or seemingly depressed adolescents. But rather than just think about depression or sadness or melancholy, you have to have a definition. And this is, we all should be working to DSM-5 criteria, which you see there on the board. I don't really think I need to go through that with you because it's pretty self-evident, it's pretty well known. But the important thing is at least a 2-week period of depressed mood and other symptoms there. So how common is it? Well, in children it's not so common. And don't forget, if we've been talking 40 years ago, you wouldn't have had this slide, obviously. You probably wouldn't even recognize that children become depressed because it wasn't thought so at the time. But children are depressed, and adolescents more so. The interesting thing is there is a distinct change in the prevalence amongst the sexes. Childhood is 1-to-1, or perhaps even slightly higher in males and females, but in adolescence, that's completely changed. That's much more common, as you know, in females than males. But look at this ridiculous figure here, cumulative prevalence of 20%. And interestingly, if you look, the prevalence of depression in Turkey, I think, but certainly UK and US, has increased since the Second World War, even though our standards of living have increased. So what is all that about? No one absolutely knows the answer to that. But, as I said just before, the prevalence across cumulative prevalence is staggering. Look at this. And it's very clearly shown here in terms of males and females here, red here. That there is a staggering increase as you go through adolescence. That's a cumulative there. But you can see here mild depression and severe depression. So, okay, so it increases across the age range. Females more than males. And the interesting thing here, and I think this is terribly important if we could do some thinking later on, is that how many cases of pure depression do you see in young adolescents? I'm not talking about children now, just adolescents. How many cases of just pure depression have you seen in the last year? Anyone see more than 2 cases with their mind putting their hands up? You have. Possibly someone else there. It is not that common. When I trained, I saw older persons, old age, then seeing pure depression was not that uncommon. But in children and adolescents, it's not that common at all. Comorbidity is the rule rather than the exception. And I think everyone would agree with that. But the important thing is that actually the severer the depression, the greater the impairment, that's obviously, and the greater rate of comorbidity. So comorbidity is the rule. And that's what makes the treatment and treatment of treatment-resistant depression that much more difficult. It is an area that requires good clinical skills to differentiate out, to work out exactly what you're dealing with. And we'll come to that later on when you go run through the results of our kind of clinic. Now, this part here is extraordinarily important. Although it's common, we've seen that, it's not recognized and certainly not treated. Ian Goodyear, who is professor of child psychiatry in Cambridge, did a 10-year did an epidemiological study of young persons, adolescents, with depression, and found out the same prevalence virtually 10 years later. But what he also found out was that the proportion of those actually receiving treatment had not increased at all. And many of the young girls, it was then, had stayed at home, withdrawn from school, withdrawn from friends, and actually when you spoke to them, they thought they were mad. They thought they were losing their mind, and not accessed help at all. Now, I don't know if that's not the same position in Turkey, but I'd be surprised if it wasn't the case. So that actually we've got a problem in accessing treatment. But of course the trouble is, if you want more people to come forward for treatment, then you've got a problem. You have to treat them. And I always find that actually very difficult. So let's have a look at the development of these problematic disorders. Because it's not clear, well, we might just be able to see in a minute, Where do these disorders mainly arise? The most common disorder early on are anxiety disorders. Then disruptive disorders, middle childhood, and in adolescence, depressive disorders come to the forefront. So it's not exactly clear that you're going to pick up depression early on. It's much later. So, this is an Oregon study here, showing that the mean age and the standard deviation there of anxiety disorders, 7.2, externalizing disorders, much the same. Dysthymic disorder, and dysthymic disorder is particularly difficult because, as you imagine, DD, as we used to call it, double diamond, the trouble is with dysthymic disorder, if it's associated later with onset of clear depression, then it becomes much, much more difficult to treat. And then major depressive disorder, according to DSM-5, well, it wouldn't be then, DSM-4 then, it would be 13. So there's a clear transition in terms of age for these disorders. Now, this is actually quite an important slide, because if you're doing anything, I don't know what it's like in Turkey, but in child psychiatry in the UK, it's much more difficult to argue for resources. And if there are scant resources for psychiatry, it often goes to those in adult psychiatry, because they say, oh, lots of our patients. But if you look, actually, at least a quarter of mental health problems arise in adolescence. No, 3/4, sorry. And this is actually showing that beautifully, really. If you really wanted to make an intervention, then treating early onset depression might be quite important, because the idea that actually depression increasingly becomes more difficult to treat. And here's the projected cumulative incidence from the relatively recent study, showing horrific cumulative incidence here. Now, this is one of my colleagues, Adrian Angold, who's now retired, but actually showed, I think this is quite an important, interesting slide, really, because what it shows, it's not age that's the important factor in depression, the onset of depression, it is pubertal status. So that the more developed pubertal young person, the greater the risk and the greater the difference between the males and females. Now, why is a whole host of answers for that one. It could be hormonal, it could be societal changes and so on, things like that. It's difficult, and I'm speculating here now, but one of the things that we've noticed in the UK, and I don't know whether it's the same in Turkey, but there's been a recent survey of sexual assaults in schools. And I don't know if that's a problem here, but certainly it is in the UK. And actually, a good percentage, 60% or so, of young female students will say they've had some sexual innuendo or some sexual behavior or connotation. And these aren't minor. So there is a real problem we have, but I'm probably digressing a little here, but it's certainly a very big change. So is depression that big a game? Yes, it's the major cause of mental health impairment and struggle worldwide. I mean, by a considerable amount. And this is across the age range. So this is, I think, yes, it's in the Lancet. So it's a little day, but this is a measure of impairment here. And we take things, let's just take one here, eating disorders. Well, that looks pretty bad. But it's dwarfed in every single age range by depression. So it's worthwhile you guys coming to this symposium, because you are dealing with a major mental disorder, the major impairment. So that seems pretty fair. Okay, so we have in the UK, you may know, because it's certainly well respected, and I've been on 2 NICE guidelines, and they're extremely thorough. You cannot do anything outside the guidelines. That's why they're respected worldwide. So the evidence is sifted, You cannot put evidence in without really thorough scrutiny. So the NICE guideline, National Institute of Clinical Excellence in Healthcare, is the idea of, well, what do you do with depression? And fortunately, actually, we've got some simple answers here. This is Dick Harrington actually led the way for this in terms of depression, noticing he was a late professor of child psychiatry in Birmingham and then Manchester. And what he said was, well, first of all, you have to detect it. And actually, you can do quite a lot by actually triage. So if you have a clinic, you've got young people coming, you can actually screen them, offer first-hand advice, may not need a psychiatrist, may need just a mental health worker to actually help with them, redirect. It could be quite simple things. Well, not simple, but it could be difficulties at school, bullying and so on, things like this. Do not require medical intervention per se. And we have here, and I'm going to go through this a little bit, digital CBT, group CBT, all the psychological treatments here, moderate to severe, family-based treatment. Well, that's interesting. Family-based interpersonal therapy here, 12 to 18-year-olds, moderate to severe. Now, there was a change. First and foremost, I think NICE got this wrong. Well, they clearly got it wrong when it first came out, because they said they've got severe depression. The first line of treatment was psychological treatment. And only then, after 3 months with a review, were you meant to start antidepressant therapy. Okay, which I think led many people to be in a vulnerable position for several months if they were not responding to the psychological treatment, or indeed if they were too depressed to take advantage of psychological treatment, they were left vulnerable. And of course, there is an increasing risk of self-harm and even suicide, so that really that's a very bad piece of advice. The latest guidelines suggest that actually you should start with severe depression, antidepressant treatment, if the person's willing to take that pretty much straight away. And it actually, for the first time, actually mentions here what one does if there is failure. We'll come to that hopefully later. But what about the brief psychosocial intervention? The reason why I mention this is because it works. And actually many people actually say, oh, well, there's psychological treatment in child and adolescent mental health services in the UK called CAMS, and perhaps in Turkey. They're not really worth it. They don't seem to actually produce much. That's not true, actually. There are several trials. Example is a trial of self-harm. Jonathan Green did a study in Manchester to show that despite really intensive group work for self-harm, the treatment as usual, which was prescribed as CAMS, did as well. It wasn't that the group work wasn't working. It is actually, if you do treatment as usual in the correct way, it works very well. But if you look, that belies a whole host of things. What is treatment as usual? In studies, it means that the therapist actually turns up on week 1, week 2, week 3, and so on, things like that. What you find in practice, however, is that, yes, you book appointment, and then the person's off sick, or dare I say, on maternity leave. And actually, the treatment is interrupted. That never works. I know from a different treatment modality that I use, CBTE for eating disorders, we ensure that therapy always continues by having what is known as a therapist buddy. So this person's off sick, someone else falls in for that straight away. There's no interruption in psychological treatment. The point I'm making in a rather belabored way is that the treatments you have to hand work, provided they're given earnestly and sensibly and in a concentrated form. Now, this is one that works really well. On the IMPACT trial, it was effectively as effective as CBT and psychodynamic psychotherapy. There was no difference between the three of them in the IMPACT trial at all. No difference at all. But what it means, psychoeducation, action-orientated. So you look at, if there's bullying, you need to treat that. Interpersonal difficulties, you treat that. Building health habits, that's sleep and exercise. Very difficult. I don't know what it's like in Turkey, but actually I work in an adolescent unit to get the young people to actually go to bed when they're meant to go to bed and get up when they're meant to get up and do exercise and actually go out in the sunshine and things like this. You'd think you'd ask the world. It's impossible. The more I try, the less they do. So if you can do it, please let me know how. Because it does seem to me all the self-defeating habits, like not going to bed, not getting up, not going outside, playing on a Game Boy, this is just wasting time, but certainly that contributes to it. But actually, if we go through this, diet, exercise, engagement with school, and so on, does actually work very well. And this brief psychosocial intervention does not involve any cognitive or self-reflective work, and it works. Digital CBT, well, it actually does work. I'm glad to hear that actually you may well know from your own experience, particularly proprietary names and so on, things like Sparks, Stress Busters, and Grasp. They do work, but most of the evidence suggests that digital CBT works well, works better if it's therapist guided, so that you just don't say, here's the package. You have the kind of package plus someone saying, are you following it? Have you any difficulties? Can I phone you up? So on, things like this. So modulated or enhanced, straightforward CBT packages work well. And I think, it'd be interesting to have a discussion later on, but for some people who do not want the interpersonal contact or sharing details, doing something online, I think, may offer a way of helping young people and accessing them that actually other people won't. So that's just a thought. Okay, there's a paper I've left. You'll have access to the slides, I think, after the tour, after the conference. But this is quite an interesting paper, actually. I think, Lancet by Marie. This really epitomizes or tries to pictorially indicate what we're dealing with depression. I'm not really a depression expert. I spent more of my early in research life trying to image schizophrenia, but that's another task. But the point I found with depression is, and what the hell is it? And you may well think, well, that's ridiculous. We know what it is. No, it's too heterogeneous. And that's the point I'll come to is here. Many people will have depressed mood. And if you look at the questionnaires that actually assess that, the Beck Depression Inventory and so on, things like that, they may well not differentiate terribly well between guilt, shame, anhedonia, hopelessness, and things like that. My contention is that actually they are related, but there may well be different parts or components to this. And I think the evidence is, at the moment, that actually that's a better way of looking at the overall depression. So apart from being genetically modified, severity, age of onset, we may well have to look at a more discriminatory way of actually, is this patient anhedonic, melancholic, and so on, things like this. Many of our forefathers actually spoke of that before. So the idea is that we go down this tree here: anhedonia, worthlessness and guilt, suicidal ideation. What's the prevalence of suicidal ideation in the population in the UK? In adolescents? Probably about 8%. So it's not that uncommon. I would be surprised if it isn't the same in Turkey. So this is actually quite difficult when you're in a casualty department actually assessing someone for the risk of further suicide or suicide attempts and things like that. But actually assessing mood is the crucial component here. Plan and attempt, obviously. Fatigue, loss of energy, sleep disturbance, weight disturbance, inability to think, and psychomotor retardation, and so on. So you can see there, it's fundamental symptoms, emotional symptoms, neurodegenerative, vegetative symptoms, and cognitive symptoms. So we're dealing with a complex array of problems. This is a slide I think you're going to have to digest at leisure. But I think it's helpful because it shows that actually not only is the presentation, but our treatment is extremely complicated and the response. None of the antidepressants are highly, highly selective. And I would like to engage you in a discussion with those lately. I would put it forward to you that actually that's not a bad thing. But if you look here, these are the antidepressants. Can you see it seems to be jumping up and down a bit? Is that right? Or is it just me? I haven't had that much to drink, I don't think. But anyway, but there is, oh, sorry. If we look here, these are the antidepressants. These are the transporters here, presynaptic, postsynaptic, and other actions here. And we're talking about the schematic representation here of how monoamine oxidase inhibitors work. 5-HT, presynaptic here, postsynaptic. And actually we're also talking about a complex action of some antidepressants on neurogenesis. And we can see that on actually the laboratory tests of how antidepressants, after a certain length of time, actually, through BDNF, actually increase neuronal growth, dendritic spine growth in animals that have been subject to learned helplessness situations. So this is a complex picture here, and what we're getting is, interestingly, is not all the antidepressants are similar. In fact, there's quite a disparity here. Do you think you could hold on to that? If you can just mentalize that picture here, the pharmacological responses of these medications are diverse. Do we find a similar diversity or range of therapeutic actions in terms of efficacy? Does anyone want to have a guess? Or are they all much of a muchness? Well, I've already told you the story. They're all much of a muchness, to be honest. That's the interesting thing is, here we have a very helpful guide, but it doesn't seem like that's translated into difference of efficacy. But I want this to be more of an interactive kind of show, if that's okay. Obviously, I'm slightly older than you guys, but how many people here, in younger people only, have prescribed a monoamine oxidase inhibitor to a young person? How many of us ever prescribed a monoamine? You have? No, you haven't. You're just waving your hand. You don't have any? None licensed? Do you have monoamine oxidase inhibitors licensed at all? Why? Why not? That's a very good question, because they actually work. And the point I'm making, which is interesting, because you should maybe take that up, is that they work, but drugs go out of fashion. I prescribed monoamine oxidase inhibitors early on. I remember one adolescent who took that. She'd actually took an overdose. She was a very interesting girl. She dressed in a Gothic style. Do you remember that Gothic style? It was all white, everything, either white or black. And she took an overdose of lefepramine, which is not an antidepressant here, but and because it's actually safe for an overdose, she survived. And she planned this overdose when her parents were away on holiday and no one at home. So it's quite a serious event. Anyway, we tried all types of antidepressant therapy for her. Nothing particularly worked. At that time, I prescribed a reversible monoamine oxidase inhibitor, and didn't see much of her. She came in 4 weeks later, completely the same attire, because it wasn't a symbol of her being depressed. It was rather a style. Gothic was a style at the time. But she was transformed. She was much more active. She was much more engaged. And she said, I'm doing my driving test now. Previously, she remained totally isolated in her room. So the point I'm making is that we have a class of antidepressants here which we don't use. And I will show you later on that our treatment of depression is frankly rubbish. So why aren't we using a wider range of drugs? It does seem to me to be crying shame. And I think in psychiatry, we've got a lot to put our hands up to. Our colleagues in general medicine combine drugs. They use different types of drugs, different ranges. That's why they've conquered HIV and many cancers. Whereas I think for psychiatry, we're not that medical, and we've taken our eye off the board, and we don't treat things as aggressively and as well as we should. Enough preaching, Tony. Off you go. So, he suggests that actually you may well have generic interventions, family, psychosocial, low interventions, internet-based family support groups, housing, and then absolutely interventions here which are formulation-based, cognitive behavioral therapy, interpersonal therapy. They work as well. Actually, the evidence is that interpersonal therapy works probably as well, if not better than CBT. But because CBT has got a larger industry, and I know Beck recently died, but it's got a larger industry here, not many people do interpersonal therapy, but it is as effective. Mindfulness-based therapy, I think the jury's still out on that, but there's a lot of energy into that at the moment. First line, SSRIs, SNRIs, melatonin agonist, and so on. We do not use tricyclic antidepressants in young people. Why? They don't work, which is quite interesting when you think about it, because they certainly work in adults, but they do not work. There's no evidence that they work in young people, and they are lethal in overdose, so no one does that. And I'm going to mention treatments here, ECT, and other forms of intervention, TMS, and so on. But do we combine an important thing here for treatment-resistant depression is the combining psychopharmacology and psychotherapy. That's crucial. And the evidence is that CBT does work in severe depression as well. Well, we'll come to this, what you actually do later. Okay, I have a problem, and I expect you do too. This is Andrea Cipriani, who's an expert in Oxford, who sits in an office just about 100 yards away from where I work, across the car park. And he actually, with others, have actually effectively said the treatment of depression in adolescents with antidepressants doesn't really work. In fact, he was actually on TV, and the TV presenter put down on a table 13 different types of antidepressant just represented by stars. And he says, does this one work? Does that one work? Does that one work? Does that one work? Oh, that one works then. But on the whole, he led himself to look, in my view, really rather silly to show that actually, if you come to here, the only one that really works is, as Nice said, CBT alone or in combination with fluoxetine in combination with CBT. With that kind of backing, I have difficulty when I come to my patients to say, do you want to take an antidepressant? Because if they read the newspapers, watched the TV, or read the literature, they'd say, oh, it's really equivocal, isn't it? And there is a good school of psychiatrists who actually say antidepressants are really just the handmaiden of big pharma. They should never be prescribed. There's no evidence that they actually work at all. So you've got a problem. I actually couldn't do my job if I couldn't prescribe antidepressants. I've seen it transform people's lives, and I suspect you have too. But that's not enough. But the trouble is with the trials, it's obvious, And Dick Harrington, I referred to him actually when they did the impact study and so on, things like this. Well, no, he didn't do the impact study, he did the first one. Suggested that actually a lot of the trials in the States and so on, things like that, did not reflect the normal patients you see in the clinic. And that's actually quite important, because if they're suicidal, they're excluded. But some of the later trials have included patients who have been suicidal. But I don't think the evidence really refers to the kind of cases we see all the time. But this is the network analysis on efficacy. Sorry. What's going on here? Sorry about that, my fault. Efficacy and acceptability here. But if you come to this slide here, which may be difficult, this is a straightforward pairwise analysis rather than the meta-analysis. But let me point you to something that's actually quite important. All those red dots here are very low quality evidence. Again, green is moderately quality of evidence. So the trouble is, if you've been on national guidelines like NICE and things like this, they're so scrupulous about the evidence, whether the trial's been blinded, whether they have blinded assessors and things like this, which really is scientifically sound, but actually does mean the trials are often relegated to this picture here. This is all a bit depressing, really. It becomes perhaps slightly more depressing, but don't be put off. I don't want you to become depressed in the evenings on things like this. But there's no agreed definition of treatment-resistant depression. But the consensus happens to be failure to gain remission with 2 or more adequate antidepressant trials, and some might add, an adequate and correct psychotherapy. Okay, is it a problem? Well, the British Child and Adolescent Mental Health Surveys, which are reasonably rigorous, nearly 20% of depression had been persistent for over a 3-year period. And that's in adolescence, formative years, where the person's going to school, making relationships, thinking about opposites or same-sex partners or whatever. The depressed is going to have a major impact on that person's life and things like that. And furthermore, there is actually very difficult to predict who's going to respond and who's not going to respond. But 2 things here: a family history of affective disorder, so maybe I'll be genetic, or in family environment, and an adolescent's degree of cohesion with his or her group. That's provided the group is cohesive and helpful in a way that you'd think of. It would not be helpful if the adolescent has become depressed, drops out of school, truants from school, and then links with those using drugs and illegal substances. And that is a real risk. So we've got a real problem. We're currently doing a study, because we have in Oxford and certain places in London and other parts of the country electronic records. Now, you may or may not have electronic records. They're a bane, because I'm slower at typing than I am in writing and so on, things like this. But they do have the advantage of being able, you can systematically scan all the electronic records for about 1 million patients in about a quarter of a second. And if you have good algorithms and natural linguistic programming, you can pick out the cases who haven't actually responded to treatment. And it comes to about 30%. So that's huge. It's a huge problem. So what you do? Well, you need to review the diagnosis, maximize the dose, switching perhaps to another antidepressant. This is a WHO, World Journal of Biological Psychiatry, sorry. This is including that work for adults as well. Switching to another antidepressant, possibly. Combining 2 or more antidepressants, how many people do that? I don't think anyone I know does that. Augmenting with an antidepressant with another agent, such as lithium. T3, or atypical antipsychotics. That's probably the most common. And it's got down here 6 combining antidepressants with psychotherapeutic input. That's a mistake. It should be way, way, way up there. And combining antidepressants with non-pharmacological. So light therapy, we'll come to that in a minute, waking therapy, and possibly ECT. So they do say that augmentation is probably one of the better strategies. Lithium, quetiapine, or aripiprazole. And there's evidence for that. We'll go through that in a minute. This is rather a complicated kind of review type article, so I just put it in for your information rather, but it's actually talking about a whole host of responses that we could actually think about. And it has mentioned, this is way back in 2014, so it's some time ago now, but atypical antidepressants, aripiprazole. It's very interesting. Quetiapine, olanzapine here, and we're going to talk about glutamatergic, and I know that you've already had several lectures on this, ketamine, scopolamine, and so on. So, do we all just turn around and use ketamine for treatment-resistant depression? No, we don't. But it did seem, when it first came out, here, 2006, this paper in the Archives of General Psychiatry, a game changer. And I don't know if you have a ketamine clinic in your hospital. We do, with Professor McShane, who's very earnest. We give ketamine in purely a medical setting. So it's an infusion. I know ketamine is now licensed and licensed for different forms of administration. But the idea being that actually we do not want to make it a drug of abuse. So it's regulated and so on. So we had only one patient so far treated with ketamine who was suicidal and resistant to all types of depression. So it seemed really ketamine or ECT, and we went for ketamine. And, well, I thought that if we give this, we should see pretty quick response. Has anyone actually treated a young person with ketamine in here, this room, so far? Okay. So, treated this young girl, no response. She was still lying in her bed, darkened room, talking about suicide. Second time, nothing. And she had a completely dissociative experience, so she had adequate doses of ketamine, nothing. Third time round, walking down the corridor in the unit, there she was, walking down there. I said, hey, where's the fire? It's fine, I've no problem at all. Completely transformed. It was quite startling to see someone who had actually been bedridden for weeks, suicidal, walking down the corridor saying, what's all the fuss? It was really quite amazing. Unfortunately, it wasn't straightforward, but she did respond eventually to that, but there were other factors. So, what about ketamine? Well, you do get potent, rapid response. I've seen that. Reduces suicidal ideation. There's evidence for that. And it's effective in treatment-resistant patients. Single dose, so they say, can provide a treatment response for a week or two. Well, side effects, dissociative symptoms. And actually, became quite interesting for me because you had to say to the patient, look, you're going to have to trust me because when you have the drug, if it's effective, you're going to have a completely dissociative state. And that, when you think about it, is quite worrying, isn't it? You're saying to the person, don't worry about your mind's going to go all over the place, but you're going to come back. It's okay. But it's a big step for someone to trust that, to actually think that actually I'm going to lose my mind, it's under control of my mind for a certain time, to say it's transitory. There is abuse potential, and it requires supervised, and the long-term efficacy and safety are not yet demonstrated, but there may well be, even here in this conference, some evidence about that which we might need to look at. And actually the studies, I only put this up just to show the studies in adolescents are not that well developed. So we're mentioning here a single trial here. But we do know that actually it affects parts of the brain that we would want to be involved in an antidepressant response. And so the limbic and sensory aspects. I won't go through the slide particularly. How does it work? And actually, it's a complicated picture, as you can see, because it is not just purely a glutamatergic effect. If we run along the top lines here by NMDA receptors, glutamate and AMPA, oh yes, of course, but actually has effect upon sertraline, serotonin, 5H1A receptors here as an agonist. Really? Are you trying to tell me ketamine is not a glutamatergic drug and only affects that? Yes, I am. Because watch this slide here. Because what we can do, if we use here a 5HT1A antagonist, you can block the response completely of ketamine. So it's not via the glutamatergic system. We know these interplay, so that's actually quite interesting. Okay, well, shall we ask some questions here? How many of you have used buspirone? Or as my colleague used it, buspirone. Anyone use buspirone? Good, bad, indifferent? Makes patients sick. That's exactly my thing. Aripiprazole? Yes, of course you have. Yeah. Vortioxetine? It has some evidence in children and adolescents, and we're beginning to prescribe that in our clinic. And the others, I don't know yet. The question is here, how familiar are you with the concept of biased agonism? And I'll come to that. What that really means is that the effect of serotonergic agents are complex, as you probably would expect. But the interesting thing here is that if you have a biased agonist acting on the frontal lobe here, you get immediate antidepressant response and a change in cognition. And it's rapid. Now the thing is, the evidence I shall show you is from animal models first of all, and we didn't get an MRC grant to look at this, but we are researching this in Oxford, and I'll tell you about this in a minute, to get a biased agonist to act specifically on this pathway here. But the trouble is, if you give an antidepressant with serotonergic activity in the raphe here, it actually decreases the antidepressant response. So one part of serotonergic response is to increase the antidepressant effect, and similarly, at the same time, to decrease it. So this is why antidepressants might take some time to work, although there are probably other aspects to that. We are now looking, because I thought it would be interesting, this is a Psychopharmacology conference here, NLX 101, with the colleagues who are mainly in France, to look at a specific 5-HT1A receptor here, which, look, there's ketamine acting on MDA receptor on GABA interneurons and actually producing a response here. So the idea being that if we could use a specific 5-HT1A agonist, we would obviate the need for ketamine, which has all the problems with it, dissociative and abuse potentials. And in rats, the antidepressant response, which you give rats swimming in baths and God knows what else, is immediate and sustained. So but we haven't got the evidence for that in humans yet. But I thought you might be interested to know help is on its way. Okay, this is a reasonable review, and I recommend it by Strawbridge et al., showing what really works in treatment-resistant depression. NMDA targeting agents, such we would call that ketamine, mood stabilizers, perhaps, antipsychotics here, psychological therapies here, there's a wide confidence interval there. Pill placebo does work as well. Psychological placebo and short-term treatments less so. And these are the effect sizes. But bear in mind, psychological therapies do have a part to play in this game. Just wanted to go through this just a little bit more. Lithium, so on. We have reasonable effect sizes there. And psychological therapies as well. Now, if you're going to increase, the immediate thing is, as a psychiatrist, you might think, well, I'm going to increase the antidepressant response by increasing the dose. Problem. Because if you look here, this is, I would recommend Furukawa, who actually works with Andrea Cipriani, and he's from Japan. Andrea Cipriani, as I said, is from Oxford. But it does seem to be here, for fluoxetine, a response here that's between 20 and 40 milligrams. If you increase the dose, which many of us do, you do not necessarily get an increased response. You do certainly get an increased side effects and likely drop out. So it's actually worth knowing that just increasing the dose does not necessarily give you more bucks for your money. So these are the kind of things that actually might well having a look at. Overall, DBS, deep brain stimulation, well, no one uses that, I'm afraid to say, but we can. The reason for putting this slide up here is, this is quite interesting, isn't it? Bright light therapy, which is actually cheap. You ask the patients to buy that themselves, but actually has some evidence to that. And actually what I like about it is people can take control of that themselves. And ECT, I keep on mentioning that, but I do think for very severe psychotic with a risk of suicide, then that would be. We, I think, treat perhaps 1 every 3 years adolescents with that. It's extremely rare, because we cover a population of about 3 to 4 million people. It's very, very rare. We have to do that. And become less common, I think, with the more informed treatment rationales we have outside. Wow. Where we come to now, psychedelics. Do any of you know well, you've probably read about the trials from, I always think this is very interesting, and he's a terribly interesting guy. If you ever phone him up, professor of psychiatry, Imperial College, who I think has a very apt name for a psychiatrist, Professor Nutt. But he's a terribly nice guy, and he's first class. He's fallen out with the previous government about cannabis and alcohol, saying cannabis is less dangerous than alcohol, so they sacked him off a kind of advisory body. He was quite right, of course, but there we are. And he's actually pushing ahead, saying the reason why psychiatrists in the 1960s were using psychedelics for psychotherapy and actually making good progress completely stopped because of course, the abuse. But it's perhaps wrong, because it's saying that it actually has neuroplastic effects. I've left these slides for you so you can see. It has immuno and anti-inflammatory responses too. So it may well be that they're quite useful for anxiety, depression, and post-traumatic stress disorder. In fact, we call them antidepressants, but the evidence is in children and adolescents that antidepressants are more effective as anti-anxiety agents than they are, by a long way, than antidepressants. And they have an effect upon the neurotransmitters. But the response of these drugs is complicated because they do not have an effect just upon neurotransmission, as we see down here. This was a slide from a person who's particularly interested in the bold response. That is the response you see on fMRI to antidepressants, other things. But actually saying, yes, of course it does increase serotonin release and has an effect upon constriction of the blood vessels here. But if you look also, the same drug has an effect on glutamate and actually on the astrocytes and increases vasodilation. So the actual pitching of antidepressant effects in the brain is complicated. And I think for us as practicing psychiatrists, it show that these drugs have a multiple effect on processes, not just one. And one that's actually come up to be particularly helpful. Does anyone know of which antidepressant is useful for COVID, or any of them are. Anyone heard about that? Is an antidepressant useful treatment for COVID? This gentleman has got it right. Yeah, fluvoxamine. And we've all used fluvoxamine in the past. I give it up because it makes people sick when you give it, but actually has an anti-inflammatory and is now recommended for one of the treatments for COVID, for the severely ill, those hospitalized. I have to be careful, it's not my area of expertise, I'm just referring you to this here. So what we're saying, these antidepressants and psychedelics as well have an effect not only about neurotransmission, but also anti-inflammatory and neurogenesis as well. Okay, so we're getting to the clinic now. As I say, an important thing, if you want to set this up, is don't do it as yourself as a psychiatrist. Have someone else there. Multidisciplinary does work, and Rachel Hogan is outstanding. She's done all the work for this. So what do we do? Well, we're going around in circles here, because actually I gave you a definition of treatment resistant. I phoned up my friend and colleague Angaris Trigaris in the States. He was in the Maudsley, and he's written an article here in 2020 in the Journal of Child Psychology and Psychiatry, and suggesting these be the treatment, these be the guidelines. So already he's saying treatment resistance is the person who just doesn't respond. Treatment refractory is where at least, so we've already had an inherent contradiction in terms. And I think until we get that sorted out, we're not going to get anywhere. But this is straightforward here. So, oh, sorry, it's the same slide, isn't it? Sorry about that. So we go along the NICE guidelines. We want to see what the responses are. We know that fluoxetine is the only treatment here. So we're really going in a treatment-resistant depression clinic in the area of the unknown. So what we did, we looked at the literature, and we had a talk by Richard Morris, who was the head of the NICE guidelines for bipolar disorder, which I was on. And he's professor of psychiatry in Nottingham, and he's a very earnest and strict methodologist. He works very rigorously and carefully. And he set up a clinic in Nottingham to take all the treatment-resistant depression clinics patients for adults. Big mistake, because actually what happened was that he was overwhelmed with work. It cost an awful lot of money, and at the end of the day, the results were equivocal. What we thought, we're not going to fall into that trap. We are going to do a consultative model, which I'm going to put forward to you as really being a way forward. It's not taking the patient from the clinician looking after. It's actually saying, we can work together on this, and this is the evidence, this is the way we can work, think about things. So we're going to do a consultative model. It had to be someone suffering from depression, DSM-5, without schizophrenia, substance misuse, and underweight eating disorder, because they have their own treatments. And at least one recommended, usually fluoxetine with evidence of psychosocial. Actually, it was 2. Sorry about that. There should be 2 antidepressants. So the important thing, colleagues, psychiatrists had to refer to us. And it would be a consultative process. We will not take over the care of the patient. We may well see the patient, but we're not, mostly not. Telephone consultation before the referral is made. And the important thing is that we would go through the clinic records to make sure, A, we think with the diagnosis, and all the necessary investigations, including blood, ECG, and folate levels. We know that folate metabolism is important in depression, so that all those things and vitamin D had to be done. And what we did, we used the DORBA, which is set up by Goodyear. No, not Goodyear. Robin Goodman is a computerized screening program, which you do pay, I think, about £10. You sent a questionnaire to the parents, questionnaire to the young person. It's actually quite important that you get both aspects, because many of the trials actually show there's a big disagreement between parent and adolescent. We take the adolescent version as the most important. But you do comes up with a full screening of all the diagnoses that one may be dealing with. And as I've said right at the beginning, it is very rare to get a pure case of depression. It's more than likely you're going to get comorbidity. We do not do the case SADs now. And there's a new case SADs there. CDRS. So the important thing we do is to actually talk with the clinician. We do not say we say we have some expertise and some knowledge, but the idea that's consultative is we work through the people, and that makes a big difference, I think. And we use evidence-based protocols, brief psychosocial intervention, or they will be in CBT or IPT, or occasionally DBT for those who have, say, emerging borderline personality disorder. And we would want to turn this into research protocol later on if this clinic works. This is the evidence that Rachel has kindly looked at for us, and she will be able to produce all the evidence for a skeptical psychiatrist or a patient. Why am I taking duloxetine? What the hell is this? What effects does it actually have? Well, she can give you that. So fluoxetine, starting low, increasing the dose, not beyond that. And it also gives you the evidence here. Citalopram. Escitalopram, especially in the States, is actually valued, but you have to be careful in overdose because it does have an effect upon the QT interval. And venlafaxine, now the evidence was against this according to NICE guidelines, but perhaps duloxetine is there. And the antipsychotics, aripiprazole in particular, quetiapine, risperidone, and so on. And lithium. Combination of SSRI, metrazapine, we haven't used that yet, and T3. What have we learned? And these are important nuggets, I think, for you. They're evidence-based, not in terms of research, they're just straightforward clinical things. It's not always a good idea to change an antidepressant. How many times have you changed a patient's antidepressant to just see them dive down, become quite severely depressed? This antidepressant is not doing me any good, doc. I want to come off it. Big mistake. Because it is doing something. The antidepressants are not happy pills. They stop you becoming profoundly depressed. And it may well be other factors in that person's life that needs adjusting. You stop the antidepressant and you'll see a tremendous decline often. So you may well have to actually, it may not be the answer. So we've got the comorbidity there, particularly with borderline personality disorder or post-traumatic stress disorder that hasn't been revealed, or those that actually have abuse particularly. A negative finding is important. It may well be that antidepressant psychopharmacology is not the answer. You might need to pursue other treatment options, which may be the best thing for that particular patient. And I do think, you're come here to Psychopharmacology conference, but actually you are a person. The patient comes to you for help. You get these projections, please help me, and so on. Or worse still, you get the patient project into you feelings of hopelessness, negativity, even depression. And you kind of react to that by saying, I've got to change the medication. And I think the best thing to do is think about consultation. This may well not be. The most important thing is may you need to sit tight and say, let's just look at this and hold on to it. And consultation is a very powerful option. So you can say, I'll consult with my colleagues. And that's what we offer. And the important thing is, these are the things that I think that really help. By consultation, you're empowering the person there to do that. And you think, oh yes, I can see that, perhaps this. And what we've noticed is that actually things come out in the mix. We have a view beforehand because we've read the notes, we've been through that, and say, we're going to do this for this particular case. We come out and find out we're doing something quite different because actually the way the discussion's gone and things like this, the person says, no, that won't work. Oh, I didn't know that. but something comes out, and I really, truly recommend consultation. And it can work with peers, because you're not actually taking a superior stance. We're saying, we're putting all our brains together, our minds together. So if you want to do a setup, this is where I'm coming to you. We think this model could work, and it could work just as well here if you're wishing to look at this model of a consultative kind of clinic. And the big thing that comes out there, I may not have highlighted this well enough, but actually the treatment of the Strawbridge paper there, aripiprazole comes up as being really an effective augmentation for antidepressant effect. It's relatively safe. It does interact with fluoxetine, so you've got to be careful with that. But I think this could be a very interesting way of setting up a trial. So the idea being, say, that you may well have in Istanbul, the center, other centers, set up treatment consultative clinics. You could all say in the same protocol, same definition and things like that. Then you would have a research platform. You'd be able to go to the funding authorities to say, we don't have that many patients coming forward, say, in our clinics in Istanbul, but taken as say, half the country, we have, and we could perhaps run a proper clinic. And I think it's a cost-effective way of actually looking at this. And if you wanted to, certainly get in contact with myself, who I think the other person probably who makes a lot of sense is Agiris Stringaris in an IMH in the States, would be another person to consult if you wanted to consult more widely. I hope that's right.
Dr. James'e çok
Thank you very much, Dr. James. Every presentation has a take-home message, but this is like a take-home presentation, and we have made...
Sorry? You don't have translation? Sorry? Yeah. Can you hear us? I can hear you now, but I don't have translation. Sorry.
Sizi duyabiliyorum ama çeviri için kulaklığım yok. O yüzden duyamıyorum.
just the headphones for... So I can continue in English. I was saying that, I was saying that all the presentations has a take-home message, but this was a take-home presentation as the whole. So thank you very much for all this information. This is the concept why our presidents are here, and I think they are so happy to be here and listen to the presentation, because this is the concept that we were talking about before this Congress. Thank you very much. And the headphones are coming.
I think this lady is going to come with the translation. Thank you.
Yeah, please.
Thank you. Thank you very much.
Ladies first, Dr. White. Please.
So I've got
Dr.
hearing
White.
aids and this. Oh, God.
Can you hear me? Okay, thank you.
Okay.
Hello, thank you for the interesting, very interesting presentation.
The question is in English.
That's okay. So can you hear me?
Yeah, my glasses are coming off now, but apart from that, I'm fine. Carry on.
You know, very early in your presentation, you talked about comorbidity. And essentially you said comorbidity is not the exception, it's more the norm than the exception for these adolescents. So I'm curious how you, how do you conceptualize the heterogeneity of the disorder, other disorders that are comorbid with depression? Do you think they're part of the disorder, or do you think they just happen to be separate, or and then can they contribute to the challenges in treating these youth? Well,
this is a terribly important question, really, because I emphasize this rather a lot in my talk about the comorbidity, but I didn't really make the point that the depression is probably going to be the most important thing to treat at that point. So that, let's just take one disorder that really is extremely difficult to perhaps deal with, those patients who have an emerging borderline personality disorder. Now, which I think is rather a difficult diagnosis to make, but it's clearly, for an adolescent psychiatrist, a major problem. Often the young person has difficult relationships and may well have had a history of abuse and so on, things like this. The problem is that they may well be functioning okay in the community until they become depressed, and then their functioning deteriorates so that actually you get increasing risk of self-harm. The suicidal attempts become much worse. And I think then it's quite legitimate to actually treat the depression as such. And it's in fact vital, because you have this risk of self-harm, risk of suicide. So we're not trying to downplay the fact that actually the patients need treatment for their depression. In fact, I would say absolutely do. But it's not like, I mean, I've only had one patient recently in the last 18 months or so who was so depressed, he says, I just want to walk under the ground and be buried. You know, he was so profoundly depressed and no other problems. Whereas I have all the time young people who say, I want to die and have got abuse and so on, things like this. Recently got a patient in, just to give you an example, who'd been through the TRD clinic and had various combinations of medication to try to help undoubted depression. But she comes in, it's crystal clear that actually she has much more psychosocial problems and things like this, and it's hugely problematic to the point where she has to go to an intensive care unit because of her unregulated behavior and self-harm. There's no way in the world that simple antidepressant changes are going to make a difference to that. She does need treatment for depression, but other treatments as well. I don't know if that answers your question, really. The point being, I think that treatment of depression in comorbid disorders is as important, yes, but it's not going to be necessarily the answer to the one person's problems.
Yes, it does to answer the question to some extent. If the comorbidity is related to the depression, then as you treat the depression, the comorbidities will also improve. The other option is that you treat the depression and then the comorbidities are not treated. It depends on how they co-vary, how and in your experience, do you find that the comorbid conditions get better during the course of treatment?
Well, it certainly, I mean, to give you an example, is perhaps an easier example would be that with depression and obsessive-compulsive disorder, where an eating disorder, where treating depression can actually reduce the comorbidity. I completely get that. But I think the problematic ones we have are those with the personality type disorders and so on, things like this, where everything is so pressing because they've made a suicide attempt and and actually are prescribing antidepressants and things like that. But I think you're right, in the normal course of events, actually treating, say, a patient who's severely depressed and has obsessive-compulsive disorder, as you treat the depression, so the obsessive-compulsive problems, if they're not primary, certainly improve, even if they're not. So I tend to agree with you about that. It's those where you get dysregulated problems, where everyone's pressing, please give me an answer, and that TRD clinic might say, actually, it's not the right place. Although treatment of depression is important, it's not going to answer everything.
Can I ask one other question that's I just have a curious question. So you mentioned the case of the goth, the girl with the goth. Yeah. I don't see that much anymore. Do you think it's replaced by some other aspect? What do you see that youth are kind of playing around with?
Well, it's an interesting case. And it's never simple. This is the trouble with an adolescent psychiatrist, especially an inpatient psychiatrist. You alter all the kind of things at the same time, so you never know what works. You just hope that things work. But you're quite right. She actually was in a residential placement but she was in, it wasn't a specialist placement, it was just a children's It wasn't, it supported lodgings. But it may well that had an effect. But she felt just completely transformed to be able to get out the house. And the point I'm making is we've got a class of antidepressants here that none of us in this room actually use. I think that's just rubbish. Frankly, I do. And I think that if we were HIV specialists, we'd probably think that's remiss. We just aren't experimental enough. That's what I think.
Thanks.
Hocam.
I'm all tangled up here. Sorry about this.
Professor James, many thanks.
Not professor, I'm afraid. Well, no, I'm quite
Dr.
glad.
James, many thanks for this wonderful talk. It was quite erudite to me and also very elaborative. I would like to ask whether a combination of bupropion with any of the SRIs would be any treatment of choice for adolescent patients, because this is a strategy that is often used in adult patients. Would you like to combine bupropion with any SRIs in treatment-resistant depression in adolescents? What would you think about this idea?
This is why I do it with this pharmacist as well. No, I'm serious, actually, because one of the things having a pharmacist working alongside me is that we can check with the latest evidence and database worldwide. She can have that there. I mean, I should know these side effects and the risks associated with doing that, but actually I've got to admit I'm not always completely up to date, even though this is an area where I'm hopefully going to research. So I think to answer your question is having a pharmacist as well to get that information. And because I'm also a child and adolescent, well, I am just a child and adolescent psychiatrist, so I don't always look at the literature for coming down from adults and where she does. So this is what I would suggest to you, is don't do it as a unidisciplinary activity. Do it. And in fact, she's totally smart and does all the work. She writes letters afterwards and things like this. I'm being a bit frivolous here, but I do think it's an important point to have a pharmacist aside to you so that actually you can gauge that. And the other thing is that you have to work in this consultative model with your colleague who actually takes the risk, because he might say, or she might say, no, I don't want that. I'm not going to do it because I've read somewhere, or the risk is too great, I'm not going to do that. And we have to change our model. We have to work through that with them. I'm not prescribing for that patient.
Yeah, and I would like to correct one of my remarks. We have one MAO inhibitor in Turkey, which is a reversible one, but we don't have the classical ones.
Yeah.
But we usually do not use those reversible MAO inhibitors, even in many of the major depression cases. I don't think, I wonder if our child psychiatrist friends are using them.
Maybe we'll see in Turkey an increase in MAOI reversible after this talk.
Yeah.
But it's quite interesting. I just think that, well, I tell my trainees, if you want to do research, because I used to do a lot of imaging research at one time, but it's a mountain of imaging research done now. I did it at a time when it wasn't that many people doing it. So I said to trainees, it's best to do research ahead of the field or at the back. Don't do it in the middle, because everyone is doing it. Go back and actually look at what did your predecessors do, and they treated with MAOIs and actually made an effect. So maybe doing that, a trial of that might be helpful. So that's just a thought.
Thank you.
Well, I think you guys deserve a break.
May I
Any other
ask
questions?
a question, please?
Oh, go on.
May I ask a question?
Sorry?
Can I ask a question? Is
You
it possible?
can.
Okay. Türkçe mi sorayım?
Should I ask it in Turkish? Can you hear me?
Yes, I can.
Okay.
Pediatrik duygu durum bozukluklarında
In pediatric mood disorders, tricyclic antidepressants are not working. Why is that, do you think? What do you think about this? Why aren't tricyclic antidepressants not working for pediatric mood disorders? What do you think about this? Pediatric OCT, for instance. Tricyclic antidepressants are effective, we see this, but for pediatric mood disorders, it's not much different than placebo. What is the reason behind this?
I said you could ask a question. I didn't say an impossible question to answer. No one really knows, but the answer is that they don't. And it's been shown for some while. But it's an extraordinarily interesting question, isn't it, really? Because tricyclics clearly work in adults, and they don't work in children and adolescents. You could ask, well, maybe the research isn't really showing that, and I think we have to go for safety first. So maybe, and there wouldn't be much benefit, because even in adult psychiatry, I'm not sure that the tricyclics are always that much better than alternative antidepressants. So I think it's a risk profile. There wouldn't be much to gain from that. The only exception, and I think it would be an exception, would be if you've got a parent who's responded well to an antidepressant, say amitriptyline or something like this. You might well see from a psychopharmacogenetic viewpoint that would be a sensible thing to do. But actually, the number of adolescents who take their parents over antidepressants is quite high. So it's just not worth it, really. Okay.
Thank you.
Well,
Başka soru katkı var.
Any other question or comment? If not, can I ask one more question? With your permission, one more. Fluoxetine has a differentiating effect. Is it because of its long half-life? Because among SSRIs, it is really effective and it affects many molecules in the brain. But fluoxetine in particular has a distinctive effect, and it's like a long-acting SSRI, and it reduces the compliance problems. And if you miss the dose for a couple of days, you still see the effect. Could this be related with all these factors? Because in adolescents, sometimes they don't take their drugs regularly. It's a problem for them. They don't take their drugs every day.
Terribly important, and in fact something I missed out really. What is the major reason the antidepressants don't work, as shown up in the Torida study? That was a treatment, there's a study looking at treatment-resistant depression in the States. It's now, I think it's 2008, it's quite an ancient study, but it's the only one. The reason why is 30% of the adolescents did not take their medication. And that will be the reason why a good number of your patients will not respond because they don't take the antidepressant. And when we set up the clinic, I actually thought one of the most important things to do is actually have a pill count or something like that. I think you're completely right. So the advantage of fluoxetine is got a long half-life. Of course, that is a problem when you change medication and things like that. But I think we underestimate the fact that people do not take their antidepressants. And I always tell patients they need to continue their antidepressants for about 9 months to a year afterwards, as following the adult protocol and so on, things like that. But yeah, I think we overlook the most simple things first. The patients don't get better because they're not taking the medication, yeah. Well, I think that's about all I know. So if that's all right with you, I'll say
Yeah, I think.
good night. Thank you very much.
Herkese çok teşekkür ediyoruz.